Now, how many people in the audience actually perform echocardiography? Okay. Now, how many people interpret the echocardiographs that are done? Okay, so majority are consumers of the service of echocardiography. Good. Well, I am going to, in the next 45 minutes, convert all, all the consumers of echocardiography to readers of echocardiography. So help me God. Uh, this is what I'm going to cover, because although the billing for this session says normal and abnormal echocardiography, just like everything else, the little I've heard when I've been part of this conference, things have to be framed in a context. Otherwise, it's abstract and it will be meaningless. So I am going to show you echocardiographic anatomy. And I'm going to give you a very brief overview of how the data is actually acquired. You might wonder, why is that necessary? There is a dictum in computer science that says garbage in, garbage out. So if people don't actually collect the data correctly, a lot of the information that comes would be meaningless. And believe it or not, discerning general practitioners, when they see a report, can actually look at the report and say, this doesn't make sense. And I have to confess to you that I learned more echo from a professor in Boston who is an old-fashioned cardiologist, not an echocardiographer, but very good with his stethoscope. And we would read these reports, and we would tell him that his patients have some valve disease or some severity of heart failure, and he will come and he will say, look at your images again. You have to be wrong because I'm right. And often he was right. And he taught me this lesson, that there are always two sides to any story, and as graphically as possible. So for somebody who deals in imaging to make that confession, you can appreciate the value of clinical intuition. Okay, this is all that we deal with. Here is a torso, and as you can see, this is really how the heart is situated in most people's chests. Now, like an elephant, to get the full perspective of an elephant, you have to observe it from different viewpoints. Otherwise, you would think an elephant is just a big tusk or a big tail or just a wall. But when you go around, you get the full perspective. The same thing with the heart. So the perspectives through which we view the heart are called acoustic windows. So we have several of them. We have, this is the sternum, so we have the parasternal window. So images that we obtain by looking, by placing the, what we call transducer, which is like our microphone, or we place that around the sternum, we call those parasternal views. Now, we can bring the transducer to the axilla, where we would be looking at the apex of the heart. So we call those apical views. And this is the xiphoid process here. Through the space between the xiphoid process, we can look at the heart from here, and we will call those xiphoid views, and then we can look from above the sternum. Now, in any view we look at the heart because it's a three-dimensional structure in orthogonal planes. So, if we look so that we are slicing the heart like this, then we will say we are looking at the long axis view. So it will be parasternal long axis. And if you cut it like this bevel here, like you're slicing a loaf of bread, we will call those short axis views. And then the apical, the nomenclature we use is 2-chamber when we cut it lengthwise like this from here, or 4-chamber when we look like a fan at the ventricle so that we will get images that have 4 chambers. And I will show you very quickly examples of those. Now, I don't know why this is not showing, but this is what they look like anyway. So this is the parasternal view, and you look at the anatomy now, because this is the aorta. So you see aorta there. Behind the aorta is the left atrium. So that means this structure here is the anterior leaflet of the mitral valve, and that is the posterior leaflet. Now, because you're cutting through the front of the heart, the right ventricle is here, so you get a little bit of the right ventricle. This is the right ventricular wall, and this then would be ventricular septum. And so this is left ventricular cavity. So we can look at the septum, and this is the inferolateral wall of the heart. Now, if we do the bread loaf slice, you would cut this heart like this in circles, and you'll see the short axis. And because you can make several slices of this, if you slice it right there, that will be apical short axis, mid cavity, mid ventricular, and then the basal. And basically, the rest of this is just showing you what happens, and this is what they really look like in real life. So that is a parasternal long, and this next one is the parasternal short, and that is the apical 2-chamber, and next is apical 4-chamber. So how is it performed? I've just told you the location. To get the full perspective, you actually have to look up and down, sideways and up and all that. And the reason this is relevant is that, yes, we say apex is 5th left intercostal space, mid-clavicular line. But that is not gospel, because God doesn't have to take permission from anybody, can put the heart anywhere he likes. And so some people's heart is pointing towards the axilla. Some it's pointing towards the stomach. Others, it's very high up. Others, is very low down. But if you stick to the principle of scouting round, then you will get all the information you need. Might not look the same way as these pretty pictures I've shown you, but you get the data. And so there are different movements we do. Slicing, I wouldn't go into that. I'm just showing you how all of these can give you very comprehensive images. So you see from this image, for example, you can rotate it. As you can see, this one is showing less of the aorta. So if you tilt it more up, it will show more of the aorta, but show less of the left ventricle. And if you rotate it, this descending thoracic aorta, which is behind the left atrium, can look like a tube. And some of these images can be life-saving if you know what you're doing, because you have somebody who has a dissection of the aorta right at the bedside in the emergency room. You can make that diagnosis so that you avoid giving thrombolytics for the chest pain, which will just finish the patient off. Now, the short axis also use SLAN, and these are images you can get from short axis. And you can see each of these tells us different things. That is the fish mouth of mitral valve, so that if this mitral valve is deranged, it wouldn't open like this. This is the Mercedes-Benz that most people have, although some people are born with Opels instead of Mercedes-Benz, because their aorta has only 2 leaflets. The rest of us have Mercedes-Benz aortic valves. And this is the mid-papillary level, and this is more apical level, all through the short axis. Now, this is also one way we can tell if there is regional wall motion abnormality, so that you can actually see different segments of the heart, so that you can pinpoint reasonably well the anatomy or the coronary artery territory that this belongs to. So, and this is the subcostal or subxiphoid views, and that's suprasternal view. So, now, to make sense out of this, like everything else, you had the psychiatrists talk about DSM-4 and ICD-10 and all that. We have to have nomenclature, which means that we have to agree on certain standards of quantification that will be universally recognizable. So the American Society of Echocardiography has the guidance about how we would do this, and this is one measurement. You could take this measurement from the short axis, but most commonly we do it from the parasternal long axis now, because the image quality is so good. You don't have to do it just in the short axis, but we can do it from the M mode or measure it directly from the 2D images. But we would measure the diameter in diastole. I don't know if it shows very well. There's ECG here, so the tip of the R wave usually corresponds to end diastole. And T wave on the ECG usually corresponds to end systole. But in echo, we would actually use the mechanical diastole and systole. As you can see, this cavity, this is left ventricular cavity. If you drop an ice pick from here through this heart now, you will cross the right ventricle, which is that. You cross the septum, which is that. You cross the cavity, which is that. You cross the posterior walk, which is that. And you cross the pericardium, which is that. If you ever see any of these images, just look at the scale on this thumb print and map it to the square. So if you see anything around number 5, then you look at number 5 here. That is what you are seeing in M mode or motion mode. This would allow us to do left ventricular mass. Because we are all of different sizes, it makes more sense to index this to body surface area. And in cases of these measurements of mass, they're actually best indexed to height to the power of 2.7. But that's just that's a detail. Now, from the apical view, this is what most people want to know about echo. And it's always very disappointing for me that I will spend 35 minutes obtaining all of the data and all that, and they've called, what is the EF? Now, buyers beware, because if you only look at EF, you would most certainly get the wrong diagnosis a lot of the time. Because if you calculate, look at this, end systolic minus end diastolic volume divided by the end diastolic volume. If somebody's end diastolic volume is 5 times the normal, and their end systolic is only 3 times normal, ejection fraction can actually look normal. But that person has a core bovinum and has very poor prognosis. So whereas it is true that a very low EF always represents an abnormality, a very normal EF is not always normal. And even if the EF is normal and the cavity is very small because the walls are thick, the prognosis may just be as bad as if they have a dilated heart. So always look at the other things. So we look at the left ventricular mass, and that's when you read there is left ventricular hypertrophy, what that is really trying to tell you is that either the wall is thick or the mass is increased. There are different ways to calculate ejection fraction. These are some of the ones, but the commonest method we use is the biplane Simpson, where coins, disc-like coins, are electronically stacked one on top of the other inside the cavity, and you calculate the volume of the coins, and you calculate ejection fraction that way. We measure other things. So linear measurements of this is a short axis. This is the Mercedes-Benz I was telling you about. That is the aorta, that is tricuspid valve. So this is right ventricle, and that is pulmonic valve. We measure those things, and there are standards, indexed standards to what normal is. You can do linear measurement of the right ventricle, but in fact, one of the things that I am part of, the largest collection of right ventricular area measurement, where we showed for the first time that, in fact, these numbers are different in men and women and according to ethnicity in a very large population, over 2,000 patients. So these are different measurements. Now, we can also look at the regional wall motion. And again, we have nomenclature. So the things that are closest to the valves are basal level. The things that are closer to the apex are apical level. And then, depending on which perspective you look, you will have apical anterior, you will have mid anterior, or basal anterior. So you do that for each of the walls, and coronary circulation goes along these lines so that you can determine where the coronary disease is from, or wall motion is. We also, apart from the anatomy, we can track the movement of red blood cells using Doppler, the same thing that radars use. So the ultrasound beam sends signals. Red cells that are moving will bounce the ultrasound back, and the transducer will decipher those images. Because you know the frequency of the sound waves you are sending, and you know the speed of sound through tissue, you can calculate the distance the reflection you are seeing would have had to come from. And there are different modalities. Luckily, we don't have to do this manually. But that is the whole principle of Doppler. There are different Doppler modalities. If you continually send and receive, then you are doing Doppler in continuous wave. But if you send pulses, stop, and wait to get the signal back, that is called pulse wave. They have advantages. If you're doing it this way, then you know that because you stop listening, the signals you get, you can identify exactly where those signals come from. If you're sending continuously, then what you are going to pick is the fastest velocity along the line of interrogation. There is convention. When you look at those things, and I will show you some examples, when you see the red color of the Doppler, that means it is measuring red cells that's moving towards the transducer. And when it is blue, it is signal that is moving away. So if you remember, blew me away, blew away. That means signals going away. This is one of the pet peeves. So if you ever have a person that the echo is telling you have severe aortic stenosis because they have a gradient, or you hear you think the patient has severe aortic stenosis, the echo is saying there is no stenosis, always check to make sure that that echo data has been accurately collected. Look at this now. This is velocity through the aortic valve from the suprasternal view. That's the aortic arch. If you listen at this angle, this is the direction of flow. You listen at this angle, you see 1 meter per second. But if you actually, as parallel to it as possible, the velocity of that jet is actually double. So because this angle, what you get is the cosine of the angle that you make to the incident jet. This is very, very important. And this is where clinical judgment would make you suspect. So if you are getting reports that don't tally with what you think the patient has, don't be shy to ask whether there are corroborating evidence. So someone shouldn't just tell you your patient you think has aortic stenosis doesn't have it because they think the velocity is not high enough. Then ask them, what does the valve look like? If the valve is not opening, then even if the velocity is not high, they have to be able to explain why they have low velocity. And we can calculate stroke volume. So basically, this is the funny thing was that when I started my training in cardiology, all hemodynamics were done in the cath lab. And that was the part that I actually liked because you had to fool around with the computer, you had to do a lot of calculations. I really didn't like the doing the angiogram and all of that. I just got bored about that. But then Echo started doing all of this and better. And Echo can be done faster and bring money so that cath lab can do more angioplasty and bring money. And basically, hemodynamics got kicked out of the cath lab. But just so you know, most of the numbers we can get in the echo was originally derived from cardiac catheterization, but we can pretty much get everything now. So what are the applications? So now I come to where this talk was supposed to begin. I gave you the preamble, and I'm just going to now show you how do we use all this information I've just given you. This is an example. Now, I'm not going to talk about this. It turns out, just as you have technology, we started with black and white pictures, and then we have Polaroid, and now we have digital color, and we have 3 dimension. It turns out that when I don't see the heart very well, I can take a torchlight into the heart and light it up. That's what you're seeing here. These are studies, these are images that on their own are not very good. We inject a solution which is engineered perfluorocarbon bubbles. They have the dimension of red blood cells. They go through the vein, they go through the pulmonary bed, and they come into the left ventricle. And when I send my sound waves to it, it causes nonlinear resonance so that it gives very, very strong signals. And that signal will then be amplified. I can suppress other signals that are noise, and I would see this thing lining up the left ventricle. So you can actually see the left ventricle here now, and you can even see the intramyocardial flow. The white blush is there. So this is called echocardiographic contrast. My ambition one day to bring this to Nigeria. But this is a stress test, which just shows you the different regions of the heart. So you can see this is labeled 2-chamber parasternal long axis, and this is apical long axis. We can look at each of those segments, basal level, mid level, apical level for each of these planes. And we can see the septum, basal and mid septum, basal and mid inferior wall. We can do this. This is an example of a normal study. Why is it normal? If you, in your mind's eye, draw a line through the center of this, then you will see that this wall and this wall are moving together as if they are converging, clapping to meet that point. So these 2 segments are contracting symmetrically. You come to the midsection and you see the same thing. This wall is moving towards this wall. Go to the basal section, you see that. So this is in the 4-chamber view. And this is the same thing with 2-chamber view. During diastole, the cavity is bigger, systole is shorter. And they are all converging towards that central point. You can see. And if you draw the line here, imaginary line through here, you would see the same thing. That this thing is getting tired. Let me quickly move to the... Now, this is an example of somebody who is not normal. And you can see right here, it's the same person at rest. Everything was moving. With stress, you can see this apex is now, this is the rest image, which you can see here, and you see the apex is now blown out. You can see that this area is not moving. So this person has a critical left anterior descending coronary artery. this is the apical, this is the two chamber, this is anterior wall, and look at the anterior wall here is completely flat. The inferior wall is still moving. So this is one application where we can actually tell which coronary artery disease is abnormal or make the diagnosis that the cause of the symptom is coronary artery disease. Okay, so this is an example of another person. This person has shortness of breath and leg swelling. We take one look at this and I'll show you what he has. This is the parasternal short axis. You can see because the heart is sliced like a bread loaf. Okay, so you see this one looks like a sliced round tube. You can see it's round, symmetrical. That is the papillary muscle, all areas contracting. Look at this. Looks more oblique, like a D. This is right ventricle. Septum is flat. This is still round. The only way this can happen, remember, left ventricular systolic pressure is, let's say, 120, diastolic 80. Right ventricular systolic pressure is 15, diastolic is about 5. So the only way the septum can be flat like this is if the pressure in the right ventricle is higher than the pressure in the left ventricle. And if that happens, that's what we call pulmonary hypertension, or at least increased right ventricular pressure. It could be due to pulmonary stenosis. But the pressure in the right ventricle. So if somebody is short of breath and they have this picture, that is pulmonary hypertension. And so the job then is to go and look for why they have pulmonary hypertension. Okay, let's go to the next one. And this is the patient again, the same person with the leg swelling and shortness of breath. This is the apical view. Normally, the right ventricle is about 1/3 of the size of the left ventricle. You can see it here. This is the right ventricle, that is the left ventricle. Here it looks as if I flip them around. The right ventricle here is much bigger than the left, which is small. And you can see the septum curvature. Instead of the curvature being convex, it is concave. So again, this is right ventricular volume and pressure overload. And once you see this, the next job is to find out why. And this is why we can measure using Doppler, we can measure the pressure gradient. So we're actually showing that the pressure gradient between right ventricle and right atrium is 60. If right atrial pressure is, let's even say 5, that means this patient's right ventricular systolic pressure is at least 65. That the upper limit of normal is 30 to 35 depending on the age. So the pulmonary pressures are high. And so with echo, without doing much, right at the bedside, you can make all of these diagnoses. So this is the summary of what I have just shown you. Okay, now show you another example. So this is something similar, and now you can get familiar with this. This is the left ventricle that is being squeezed here. That's the right ventricle that is much bigger there. In fact, you can see how much bigger the right atrium is. I'm showing this in different views. That's why it's moving. This is showing the right ventricle, right atrium. Look at atrial septum is bulging towards the left. Left atrial pressure should be higher than right atrial pressure. So the septum should be concave into the right atrium. But this is the opposite. So again, this person has right ventricular volume and pressure overload and right atrial volume overload. And you can see why. That is the Doppler, this is the tricuspid valve here, and you can see the jet of blood coming back. That is severe tricuspid valve regurgitation. And you can see the pressure. You might not be able to see it on your screen. It's about 80 millimeters of mercury. And that's why this right ventricle is big and thick. Okay, so those are two examples of pulmonary hypertension. This is another patient. So the same complaint, the person is dyspneic and has a respiratory rate of 40 per minute. So one person had pulmonary hypertension, but this person has something different. And you can see, without me telling you, if you look at the aorta should have the same size as the left atrium in the diameter and as the right ventricle. You can see this left atrium is almost twice the size of the aorta. That's that tube. And this left ventricle is just big and it's not doing much. Look at the short axis of it here. Sorry, it is playing very slowly, but it actually makes the point. At least you saw the normal one that was clapping vigorously. So if they were in church, they would think this person has no faith because he's not clapping well compared to the other one. And this is the 4-chamber view. And you can see, so in fact, although it's not really as bad as this is the system that is a little slow, but you can see the walls are definitely not in a hurry to come close together like the one I showed you. So this is a dilated cardiomyopathy. And so when you see, now, dilated cardiomyopathy to an echocardiographer is not the complete diagnosis. You have to say why. And you have to see if you can find out. Is it dilated because the valve is abnormal? Is it dilated because there is pathology, a regional wall motion, and so on and so forth? So, and we use Doppler. So when you see reports that say left ventricle is dilated and there are markers of increased left ventricular filling pressure. So here is the pet peeve I have. So if you are the doctor taking care of this person, and this is what it looks like the first time you met him and you ask for an echo, and we tell you ejection fraction is 25%. You can ask for echo every week if you like. The EF of 25 may never improve any better than 35. But you can have this person with EF of 15, and you will find that they can play a full 18-hole golf, and you see another one that has EF of 50, and they walk from their bedroom to their bathroom, and they feel like collapsing. So the ejection fraction does not tell you all the story. What tells you whether a patient is going to be able to function or not is whether when they try to do something, pressure builds up in the left atrium. So it's the filling pressure that actually dictates if the patient goes into pulmonary edema. And think about it. You have a patient in acute pulmonary edema, you give them a shot of Lasix. Someone who looks like they're about to expire would actually feel well enough to give you their history. You have not changed the ejection fraction. What you have done is reduced left ventricular filling pressure. And all the medications we give, the objective is to allow the heart to function whereby with functioning, filling pressure does not rise rapidly. That is basically all that we do. And that's why it is more important not to focus on just giving them Lasix, but to give medications that would improve the intracardiac hemodynamics so that filling pressure will not go up. And if you are then discerning, you don't send the person for repeat echo and say, what is the EF? You will say, what is the diastolic function? So that you get the EF and you get you get a comment about the filling pressure, and that would allow you to marry the diagnosis of the heart failure yesterday and a patient who can function today, or somebody whom you think you have treated effectively and they still cannot do well. So it's the filling pressure, and that can be assessed by modern echocardiography. But like with everything else, it has got to be done by people who know what they do. Now, this is something that is very topical in Lagos now. And I'm going to I'm just going to have a volunteer tell me what they see. This is a 4-chamber view of the left ventricle. Can anybody volunteer just a description of what you see? That's the inferior vena cava. This is 4-chamber. Look at the right ventricle, very big. Left ventricle, very small. Apical portion of right ventricle is moving very well. The free wall of right ventricle is hardly moving. There was a big jet of tricuspid regurgitation. Left ventricle is very slow. The heart rate is 99 beats per minute. Septum is flattened, the D shape that I was telling you. Free wall of the right ventricle not moving, apical portion is moving. That's what we call McConnell sign. If you see this, think of Goldie, acute massive pulmonary embolism. And if you recognize this and you can quickly give the patient some form of anticoagulation, you might actually save their life. This is this person. This is a CT scan showing multiple pulmonary. You see this pruning? This is the main PA which should send branches like a tree. You see this thing here as a blood clot that has blocked it. And you can see that here. So you can see the upper portion still has a little bit of veins, but this whole area is bereft. So basically something blocks the fuel pump that goes to the carburetor. The car stalls. And that's what acute massive pulmonary embolism does. Most people can get away with little ones, but if there are many and they occupy strategic areas like this, unless you can go and dissolve that clot, or you pray hard and nature dissolves it for you, which happens, the patient is toast. This is another case of progressive breathlessness of 8 months. So this person has been treated for malaria. And the problem is she's been coughing bloody sputum and has very noisy breathing. And of course, I love this. So when I ask my fellows, what did the auscultation say? They'll say, oh, the chest was very noisy. And that's an excuse you can't really argue with. But they didn't say it is what is between the 2 ears of the stethoscope that is noisy. But they just say chest is noisy. But anyway, this person was treated for malaria but didn't work. So pulse was of variable intensity. In fact, the astute clinicians would look at this and would tell you that, okay, this is chronic. Bloody sputum, probably kind of, or if it's not tuberculosis or infectious disease, then it's probably Frottis sputum from pulmonary alveolar hemorrhage. Noisy breathing, needs oxygen, pulse is fast and variable intensities. That's like saying pulse is irregular. So this person is in atrial fibrillation. And in this environment, you have to be thinking of mitral stenosis. This is what the X-ray of mitral stenosis looks like. That is the trachea, that's the carina, the right and left bronchus. And you see this Y, it's splayed instead of being narrow. And you can follow what I'm showing you now. There's this sharp border and there's another border. So double border of this is because the left atrium has crowded the right atrium so that this border of the heart now shows a double shadow. Massive left atrial enlargement. Normally the heart doesn't have to be this big. This person also then has left ventricular failure. Or otherwise, you just have a straightening of this edge and the heart size may not be big if it's pure mitral stenosis. This low rumbling, diastolic murmur, and all that. This is what the mitral stenosis looks like in frozen image. You can see the mitral valve, anterior leaflet is knobbly, looks like a hammer, and it's heavily calcified. This is actually what we call this what it looks like. It looks like smoke. Rouleau formation, because blood from the left atrium cannot come into the left ventricle. So they pull here and they circulate and you have rouleau formation. What kills most of these people is stroke from atrial fibrillation. And you can see again, look at the size of the aorta. Look at the size of the left atrium. So left atrial enlargement. And then look at the right ventricle, which should also be just about this diameter. Look at how big it is. So you can look at this and say this person has mitral stenosis, left atrial enlargement with probably left atrial appendage thrombus, and pulmonary hypertension. So these things we can just tell. Okay, this is an example of another patient who has dyspnea. So I'm just showing the themes of what we use echo for. Somebody has dyspnea, and see if you can recognize familiar concepts that I have shown you. You can see again here now, this septum appears flat. Look at this portion of the right ventricle. The part that is attached to the left ventricle is moving very vigorously. But look at the right ventricle in this view. And just look at the free wall of the right ventricle is not moving well. So again, this is McConnell sign. The answer to this quiz is acute massive pulmonary embolism. It's not showing. So let me close by saying this person had confirmatory test. Just to show you, echo is multi-dimensional. We actually can look by using transducer that we pass through the esophagus. It's called transesophageal echo. This is an example of that. And you can see this is the left ventricle, right ventricle. Right ventricle is thick. This is the short axis. And showing that the right ventricle is, the right atrium is big, right ventricle is big. That's the aortic valve. The aorta is normal in this person. We do something called bubble test. If you see right ventricle that is big, one of the differential diagnoses is obviously an intracardiac shunt. So we do these things called bubble test, whereby we will inject agitated saline, and if there's a hole in the atrial septum, the saline will cross from the right atrium to the left atrium. You can see this thing that is white, this remains black. So you know that this pulmonary hypertension is not caused by an atrial septal defect. So again, don't be satisfied if people just tell you, oh, there's pulmonary hypertension and they don't describe why. So the thing with everything we are doing now is if you have a diagnosis, always try to understand the mechanism. Because two things that sound alike would require different treatment. It's only if you understand the mechanism that you can adequately treat. So this is what echo is used for, at least a limited list. We use it to diagnose cardiac function, which includes systolic, diastolic function. We can use it to evaluate treatments, and then we use it for so many other things, but that's beyond the scope of this short discourse. And this is a graphic that just shows you practically everything I have told you. I told you how it's done. So if you had to do limited images, you don't have to do all of these things I have shown you because there are some things you can do that will tell you. So measurement, we do measurement of ventricular size. We look for wall motion. We can evaluate the valves. We can look for pericardial function using Doppler, and we can use the 2D images. We can measure practically all the pressures inside the left ventricle using different modalities. Then we can look at the aorta, look for things like dissection, intramural hematoma. We can look at cysts, which you will see in the mediastinum. And then we can use this to monitor therapy. Anesthesiologists would use transesophageal echo in the cardiac surgery suite to actually monitor the amount of volume that the patients have during surgery. So you don't have a successful surgery, but the patient is dead. You can be looking at the heart as the surgery is going on. And you can use it to monitor the efficacy of your treatment for heart failure. But the focus isn't just on looking at systolic function, it's also to look at diastolic function. And sometimes you're looking and you just find something that you say, what on earth is that? And that's That's where you call people like me to try and make sense out of it. Thank you.
If nobody else has a question, I have a very big question, and it comes to the pulmonary embolism because I have a feeling I'm not the only person seeing an increase in the number of suspected cases of pulmonary embolism. And my particular field, which is maternal health in the community. Question: 41-year-old lady just has a baby. She ended up having an emergency section for intrauterine growth retardation. She was of the belief that if she didn't eat too much, the baby would be small in size and therefore easier to deliver. But it got to a point where the obstetrician decided the baby was not growing and went in and did a section. Baby came out alive and well, a little on the small side, 2.2 kg. And breastfeeding started successfully, which was where I got involved. And for 19 days, she was at home happily breastfeeding the baby, and nothing happened. Whereupon she developed a pain following a kind of sciatic nerve distribution. And we were a little puzzled because we said, well, if you were pregnant, we would have said baby was sitting on the nerve. You're not. And Panadol didn't work, ibuprofen didn't work. Finally, she came to hospital one day and climbed 3 flights, climbed up to the 3rd floor and got in there sweating and breathless. 4 days later, she was dead. What happened? What we did find, because she was very well looked after in Louth, was that on day 1, chest x-ray was clear. And she had progressive signs of lung infiltration. What they thought was lung infiltration. She was hit with just about every antibiotic we know existed at the time. How could we have changed that outcome?
That sounds like postpartum cardiomyopathy. And the way that that would have been changed is clinical suspicion. There is no other magic. In fact, you've given all the information there is. They did X-ray. So if you follow what I was just telling you, they did X-ray. They found progressive infiltrate. The question is why? But if you don't ask the question why, and you just think it is pneumonia, yeah, it's okay to suspect pneumonia. But then if you start treating pneumonia and you don't wait for 5 days, before 4 days, you would see whether there, and then the whole concept of clinical medicine, which even in America is being forgotten. There is no law that says you can only see a patient 1 time a day. So you start the treatment and you find out by the evening it's not working. Without doing any test, at least raises questions. So it is possible, obviously, the causes of the heart failure now might be protein. It may even be related to multiple pulmonary embolism, but the fact that there were infiltrates in the lungs is what would have led to. We have, many of such patients have come to us, and we find that they have severely dilated left ventricles. And what's even funny is that some of those people, they never regain normal cardiac function. They will be able to function, but the heart doesn't come back to normal. But those are the kinds of things. But people like that, anywhere in the world, it is just the clinical intuition that suspects that something is not right. And the persistence to not stop until you find those things out.
Good afternoon, sir. I want you to throw more light on ejection fraction. I had a case of 2 patients. One, there was an abnormal heart sound. Heart sound was not regular. So the patient was sent to do an ECG, which reported some form of abnormalities in the ECG. So the patient was sent to do an echo that said that ejection fraction was 58. When is ejection fraction, as in the range that when a patient has, that you will say that is okay? Then another patient is on a chemotherapy. So, and she entered into heart failure. So the first ECG was done. The ejection fraction was 38%. So the cardiologist said, no, don't start her on chemotherapy, that he will be more comfortable with ejection fraction of 45%. So when another one was done, it was 40. So I was like, when do you actually say that patient ejection fraction is okay for treatment?
Okay, so if the point I'm making, the point I'm going to want to make here is technically a normal ejection fraction when it's done by echo, anything that is 55 and above is normal. And if it is 50 to 55, mild. And if it is less than 50, it's abnormal, and you can grade it like that. But the point I'm making is the fact that the first patient has ejection fraction of 58 does not mean that the diagnosis of heart failure is incorrect. Heart failure can be systolic or diastolic or mixed. And it's a whole spectrum. So that if you have somebody, so if I were reading that, I would say left ventricular systolic function is normal, but there are markers of increased left ventricular filling pressure. That's telling you that that patient is probably having things that could be compatible with pulmonary edema at that time. Yeah, blood pressure is a very difficult thing to interpret in those contexts. I'm just saying that the interpretation of echo cannot be one-dimensional. There has to be other things. So if you state this person is in heart failure, it could be that the patient is in pulmonary edema at the time you saw. But by the time the patient is getting the picture done, you have already diuresed and the patient is relatively better. No, I'm just telling you. But you will still see signs. So EF can be 58%, but if the walls are thick and the left atrium is big, that means there is a substrate there that shows that that heart is not normal. Now, in terms of chemotherapy, I hope that is being done in the context and in settings of people who actually know about chemotherapy-induced heart failure. Because using generic cutoffs for the ejection fraction is what people will do in studies, but in real life it will cause a lot of problems. In fact, that one of the areas of my interest is using more advanced technology to identify the reduction in heart function using what we call 2D strain and strain imaging before you can actually see a change in ejection fraction. So if those patients are being seen in centers where they are using the same echocardiographer who can give a qualifying information, then it will be meaningful. But if you're just going to different labs to say get the EF, or it's been done by people who are actually not experienced with that, then you have a problem. If you're doing it with somebody who has a lot of such patients, then you have to trust the judgment of the echocardiographer that is telling you to wait.
Can we comment on chemotherapy?
I would never answer that question because that assumes that I agree with the ejection fraction statement that I don't, yeah, that is what they measure. I actually have images here where I will show you two things that are measured at 40. But one is measured with half of the heart cut off because the imaging is not optimal. Those decisions better be made by people who really know what they're doing, because you could actually cause further depression or you could deprive a patient, but you cannot use the word 40. For example, if you ask me to say that I will want to see the images, I never base any decision on the report.
Okay, in order to, thank you very much, Dr. Ogunyakin. I think it is kind of evidence that we do need a lot more training on this area, because we've all fallen into the same trap of basing our clinical judgments on reports of people who may not have the training and background that we have. And it's a trap that I found a lot of us fall into very, very often, simply because it's convenient. Because the question I would have asked, just based on this lecture alone, would have been, why did they say an ejection fraction of 40? I think Dr. Ogunyakin had made it quite clear that it is pain points when a physician simply asks him, after he has explained the whole thing, the physician says, so doctor, so what's the EF? And I think that's something we're going to, if we take nothing else from this, we should take that away. That we're no longer going to simply ask for the EF, we're going to ask for the sectioning, the diagrams, the pictures, how it was done, and try and figure out. And the, what did you call them? No, you called it something else. The evidence, the corroborating evidence for that ejection fraction. Thank you very much, Dr. Kofi Ogunyakin.